will be having 2 cases, and everything will be presented by the residents, and we have eminent faculty with us to lead the discussion. So in the end, we will also have question answer session. Amongst the faculty, we have Dr. Saurabh Arora, who is a senior head neck oncosurgeon at Max Hospital, Delhi. We have Dr. Vipin Arora, who is a ENT and head neck surgeon at JTB Hospital. We have oncopathologist, Dr. Garima, who is an oncopathologist at Dharamshala Narayana Cancer Hospital, Delhi. And Dr. Ankur, who is consultant and from the nuclear medicine department at Manipal Hospital. So we have surgical oncologist, oncopathologist, and nuclear medicine expert with us. So if you have any query related to pathology part, radioactive iodine part, or surgical part, or anything related to thyroid, you can just keep typing your questions. You can keep posting it. In the end, we will solve all the queries, if not already answered. So without wasting much time, I would like to invite Dr. Sandipta, who is second year MCH resident in the Department of ENT and Head Neck Surgery at AIIMS, New Delhi. She will be presenting on management of differentiated thyroid cancer. And the faculty for the session is Dr. Saurabh Arora. And I can't see Dr. Vipin. Has he joined? Nidhi, has Dr. Vipin joined? Any idea? Hello? Hello? Am I audible?
Yes, ma'am, you are.
Oh, acha. Anyway, we will start with the session, and in the meantime, probably Dr. Vipin will be joining. So, Dr. Sandipta, over to you.
Good evening, ma'am. Good evening, all. I'll be sharing my screen. Yeah, so is my screen visible now?
Yes, yes, Dr. Sandipta, it's clear.
Okay. Okay. Good evening, all. I'll be presenting the management of differentiated thyroid carcinoma. So, differentiated thyroid carcinoma are follicular cell-derived malignant neoplasms. Now, the WHO classification of thyroid tumors in its 5th edition has undergone a number of changes, which now includes malignant thyroid neoplasms as papillary thyroid carcinoma, follicular thyroid carcinoma, invasive encapsulated follicular variant of papillary thyroid carcinoma, and the term Hurtle cell carcinoma that we've known for long has now been replaced with the term oncocytic carcinoma of the thyroid. And there's a separate category for differentiated high-grade thyroid carcinoma. So going to the management, it begins with a detailed clinical history and clinical examination, followed by investigations such as thyroid function test, ultrasonography, FNSE, cross-sectional imaging, followed by treatment proper and a follow-up protocol. So beginning with the history, we begin with a demographic history, followed by swelling-related history, features of hypo or hyperthyroidism, related to diet, which includes iodine deficient or iodine sufficient diet, any family history of thyroid cancers, and history of exposure to irradiation. In the clinical examination, we begin with a general survey. In this, we specifically look for any features of hypo or hyperthyroidism. In the local examination of the neck, we do an inspection followed by palpation. In the percussion, we especially look for any sternal dullness, which would be suggestive of a retrosternal prolongation. And in auscultation, a bruit over the upper pole may be found. A detailed examination of the lymph nodes must be done systematically. Vocal cord mobility has to be checked in all cases, and systemic examination is done routinely. Coming to the investigations, we begin with a thyroid function test, and the first test that we do is a serum TSH. Now, if the serum TSH is subnormal, only then is a radionuclide scan recommended. Next is ultrasonography of the neck. For using the ultrasonography, we try to detect whether there is actually a nodule, the size of the nodule, the ultrasound characteristics of the nodule, the amount of cystic component that is present in the nodule, whether it is located anteriorly or posteriorly, or if there is any concomitant cervical lymphadenopathy. Now, the high suspicion nodules would be typically a solid hypoechoic nodule or a solid hypoechoic component of a partially cystic nodule with irregular margins, microcalcification, taller than wider, interrupted rim calcification, and evidence of extrathyroidal extension. In the contrary, the benign nodules would be mostly cystic with minimal solid components. Using the ultrasonography, the ACR, American College of Radiology, has given us the TIRADS system, which is a unified reporting system using certain characteristics of the nodules such as composition, echogenicity, shape, margin, echogenic foci. Each characteristic is attributed a certain point, which is then summated to give us the final TIRADS score. Now, based on the TIRADS score and the size of the nodule, we take up a decision of subjecting the nodule to an FNSE. Usually, all suspicious nodules more than 1 centimeter must undergo an FNSE, which should be preferably guided. Now, fine needle aspiration cytology should be preferably done under an ultrasound guidance, and the Bethesda 2023 gives us an updated risk of malignancy for each of the categories. For non-diagnostic, it is now 5 to 20%, in which a repeat FNSC, preferably with an ultrasound guidance, is recommended. For benign, it is 2 to 7, for which clinical and ultrasound follow-up must be done. RTP of undetermined significance now carries 13 to 30% risk, for which a repeat FNSC molecular testing, a diagnostic lobectomy or surveillance may be done. For follicular neoplasm, the risk of malignancy is 23 to 34, for which molecular testing or a diagnostic lobectomy is done. And for suspicious for malignancy, the risk is 67 to 83, for which molecular testing, lobectomy, or near total thyroidectomy is recommended. And for malignant lesions carrying a risk of malignancy of 97 to 100, the management is usually lobectomy or near total thyroidectomy. Coming to cross-sectional imaging, routinely cross-sectional imaging is not recommended by ATA, and in certain specific scenarios, the specific cross-sectional imaging is recommended. CECT is to be done when there is a locally advanced disease, or there is a bulky primary, or there are bulky neck nodes and central compartment nodes which are poorly seen on ultrasound, especially in the presence of the thyroid gland. Contrast-enhanced MRI is typically a problem-solving tool whenever there's an involvement of the larynx or trachea, esophagus, vascular involvement, or recurrent laryngeal nerve involvement, which presents as a soft tissue mass in the tracheoesophageal groove. PET-CT is not recommended by ATA in the initial workup of a differentiated thyroid cancer. Certain other investigations which are not recommended in the initial workup include serum thyroglobulin, anti-TG antibody, and serum calcitonin. Next, the staging is done according to the 8th edition AJCC. Coming to the primary management of the primary, for differentiated thyroid carcinomas less than 1 centimeters, which are unifocal, small intrathyroidal, does not carry any adverse history like history of radiation or a family history of DTC, clinically N0 without any extrathyroidal extension, the recommendation is hemithyroidectomy. For lesions which are more than 4 centimeter, which are clinically T4, N1, M1, unfavorable variance, small cell, columnar, diffuse sclerosing hobnail with history of radiation or family history of DTC, a total thyroidectomy is recommended. Now, the size cutoff between 1 to 4 remains a gray zone as per ATA, and depending on the features of the nodule, where if it's a low risk papillary or follicular carcinoma, which is clinically N0 without an extrathyroidal extension, a hemithyroidectomy would typically suffice. But a total thyroidectomy may be preferred so as to enable the radioiodine therapy and increase the sensitivity of our follow-up. Coming to the management of neck, in case of T1 or T2 tumors which are non-invasive, clinically N0 papillary thyroid CA, and most of the follicular thyroid cancers, we do not require a neck dissection. Prophylactic central compartment neck dissection has to be done in papillary thyroid cancers, which are clinically T3 or T4, clinically N0, or it is staged as N1B, that is presence of lateral neck nodes. Therapeutic central neck dissection is to be done when central compartment nodes are involved clinically, clinico-radiologically, and therapeutic lateral compartment neck dissection is to be done whenever there's a clinico-radiological evidence of lateral compartment neck nodes, and they may be proven on FNSC. Now, ATA has given us a risk stratification system, which was first introduced in 2009 and thereafter modified in 2015. It gives us 3 risk categories based on the features of the nodule. Now, papillary thyroid cancer without any local or distant metastasis, wherein all the macroscopic tumor has been resected, without any local invasion, without any REI-avid metastatic foci outside the thyroid bed, without any vascular invasion, all come under ATA low risk. Apart from that, intrathyroidal encapsulated follicular variant of papillary thyroid cancer, well-differentiated follicular thyroid cancer with less than 4 foci of vascular invasion, and papillary microcarcinoma, which is intrathyroidal, also come under the low risk category. Now, microscopic invasion into the surrounding structures, presence of REI-avid foci outside the thyroid bed in the neck in the first post-treatment scan, aggressive histologies, multiple vascular invasion, and presence of lymph nodes more than 5 and size criteria less than 3 centimeter come under the intermediate risk. And ATA high risk constitutes of macroscopic invasion into the perithyroidal soft tissues, that is a gross ETE, distant metastasis, incomplete tumor resection, and postoperative serum thyroglobulin, which are more than 10, which is a suggestive of distant metastasis, pathological N1, and any lymph node more than 3 centimeters, and follicular thyroid cancer with more than 4 foci of vascular invasion come under the ATA high risk. So, whom do we subject to a radioiodine therapy? Now, ATA suggests that the ATA high risk, in ATA high risk, RAI adjuvant therapy is routinely recommended. And whereas in ATA low risk, it is not routinely recommended. In ATA intermediate risk, there is no level 1 evidence to suggest whether it is beneficial or not, but depending on certain features like a tumor size more than 4 centimeter, microscopic extrathyroidal extension, which is conflicting central compartment neck nodes and lateral neck compartment neck nodes, there is role of RAI adjuvant in these scenarios. So what are the goals of RAI treatment? It is done to destroy the remaining normal thyroid tissue, which will help us to facilitate our follow-up, to diagnose and treat any microscopic disease, thereby reducing the chances of recurrence. The basic principles of treatment is that the majority of the follicular cells in the DTC retain the capacity to concentrate iodine. So the isotopes such as iodine 123 or 131 are used, and the ionizing radiation that is generated damages the DNA, resulting in activation of the p53 pathway, which subsequently causes apoptosis of both the normal thyroid as well as the cancerous cells. Now, there are basically 3 types of RAI treatment. It can be either a remnant ablation, RAI adjuvant, or RAI therapy. Remnant ablation is when the destruction of normal thyroid tissue is done following a total thyroidectomy. Adjuvant is when there is theoretically suspected but unproven residual disease, which might pose an increased risk of disease recurrence. And RAI therapy is when there is gross disease left over, that is, there is an artery resection, distant metastasis, and an inoperable primary tumor. So how do we prepare the patient for RAI therapy? Now, LT4 is usually withdrawn 3 to 4 weeks prior. And if the patient cannot tolerate such prolonged periods of hypothyroidism, then LT3 is initially started and subsequently withdrawn for the last 2 weeks before the RAI therapy. The target TSH that needs to be reached is greater than 30. A low iodine diet that is less than 50 micrograms per day is advocated for 1 to 2 weeks. And it is typically recommended to avoid contrast scans for 3 to 4 weeks. seafood, certain medicines containing iodine like expectorants, amiodarone, Lugol's iodine, and iodized table salt. Now, another method of producing a similar situation is recombinant TSH or thyrogen. It is indicated in patients having medical conditions like cardiac or psychiatric comorbidities that can be acutely exacerbated with such degrees of hypothyroidism, or the patient is unable to mount an adequate endogenous TSH response with the thyroid hormone withdrawal. The schedule of the dosage is 0.9 mg, which is injected intramuscularly on day 1 and day 2. On day 3, the radioiodine is administered, and on day 5, we obtain the diagnostic whole body scan. So the protocol of the diagnostic scan: low dose, usually 1 to 3 millicurie of iodine 131 is administered orally, which can be in liquid or in capsule form. The whole body scan is taken under gamma camera after 24 hours. Iodine avid tissues in the neck and the rest of the body are noted. Usually a cutoff of 0.1% is considered significant in the neck. Based on the areas of uptake, we plan the RAI treatment, which can be a remnant ablation using 30 millicurie. We all know that now a low dose is favored. And it can be an adjuvant treatment using 150 millicurie or an RAI therapy using 150 to 200 millicurie. So the target TSH is dependent upon the risk stratification. For high-risk patients, it is to be kept low, less than 0.1. For intermediate risk, it is 0.1 to 0.5. And for low risk, it has to be kept between 0.5 to 2. So coming to the response assessment, the ATA has given us 4 categories of response assessment, which can be an excellent response, that is a negative imaging with a suppressed TG less than 0.2 or a TSH stimulated TG less than 0.1. It can be a biochemical incomplete response, that is a negative imaging and suppressed TG more than 1 or stimulated TG more than 10 or a rising levels of anti-TG antibody titers. There can be structural incomplete response, that is there is a structural and functional evidence of disease with any level of TG with or without concomitant anti-TG antibodies. And indeterminate response, that is non-specific findings that do not meet the previous criteria. There may be a faint uptake on the thyroid bed on RAI scanning. The non-stimulated TG is detectable but less than the given cutoff, that is less than 1, or a stimulated TG similarly less than 10, and anti-TG antibodies which are stable or declining in absence of structural and functional disease. The follow-up protocols have also been laid down. These include for ATA low risk, those who have undergone lobectomy, the TSH goal is 0.5 to 2, and the response to therapy has to be evaluated using the ultrasound and TG testing, which is done periodically at 12 to 24 months. For ATA low risk who have undergone total thyroidectomy, the same cutoff is maintained and the periodic examination at 12 to 24 months is recommended. For intermediate risk group, the cutoff is 0.1 to 0.5 and the periodic interval remains 12 to 24, but for high risk, it should be at 6 to 12 months and the TSH goal is less than 0.1. So the timing of the investigations, the TG and anti-TG antibodies for ATA low and intermediate risk should be done at 12 to 24 months interval, and for high risk at 6 to 12 months. Serum TSH should be done at least once in every 12 months as per the ATA. Ultrasound is done 6 to 12 monthly. If suspicious nodes, the size cutoff is 8 to 10 millimeters short axis diameter. It should be subjected to FNAC or TG needle washout. Diagnostic whole body scan is done in intermediate and high risk patients who have had RAI therapy, and it is usually done at 6 to 12 months. And for low and intermediate risk with excellent response, a whole body scan is not required. FDG PET is done in patients with high risk DTC with elevated serum thyroglobulin but a negative radioiodine scan. Cross-sectional imaging is when there are bulky recurrent nodal disease, features of aerodigestive tract invasion, or when ultrasound is inconclusive but there is a high TG value. And Contrast-enhanced MRI can be done for MRI brain and skeletal survey. Elevated serum thyroglobulin more than 10, but the CT scan of the neck and chest are not giving us adequate information. Coming to structural neck recurrence. The FNSE proven central neck nodes, the size criteria for central compartment neck node is 8 and that for lateral neck node is 10. In such cases, central compartment neck dissection must be done. And for lateral compartment neck nodes, a superselective neck dissection of level 2, 3, 4. If previously it has been addressed, if it has not been addressed, then 2 to 5. For non-surgical options, ATA recommends percutaneous ethanol injection and radiofrequency ablation. Now, features of aerodigestive tract invasion is classified as per the Shin's classification, and the management is laid down in a similar manner. Stage 1 is when the extrathyroidal disease abuts the airway and touches the outer perichondrium. Stage 2 is when there is invasion of the cartilage rings. Stage 3 is when there is invades the submucosa of the trachea, and stage 4 is when the mucosa of the trachea is involved. And the management is that in stages 1 and 2, we can get away with a shaving or a window resection, and for higher stages, it may be a window resection or a segmental resection with a sleeve resection with end-to-end anastomosis. For metastatic disease, for pulmonary mets, the radioiodine that is to be used is doses 100 to 200, lower dose for older people, and it has to be repeated at 6 to 12 months. For skeletal mets, the radioiodine dose of 100 to 200 millicurie is generally used with or without bisphosphonate or denosumab therapy. And for brain mets, stereotactic radiosurgery or under cover of glucocorticoids is usually recommended. Coming to systemic therapy, the indications of systemic therapy are radioiodine refractory differentiated thyroid carcinoma, metastatic or rapidly progressive disease, mets which are symptomatic or imminently life-threatening requiring intervention less than 6 months. And the agents which are recommended are sorafenib, lenvatinib, and vandetanib. So most of the guidelines are as per the ATA 2015 guidelines for differentiated thyroid carcinoma. And with this, I would like to end my presentation. Thank you.
So thank you,
Excellent
Sudipta. Can you
Yeah.
hear me?
Yes, sir.
Okay. So thank you. It was a very elaborative presentation, and I think you have covered most of the things. There was some connection issue, so maybe I'm asking a few things which maybe I have not heard. Have you discussed the classification of thyroid carcinoma?
Yes, sir. In very brief, I have. According to the 5th edition changes that have been brought about, I have just mentioned a screen snapshot of the overview.
Okay. And have you discussed about the risk stratification before the histopathology?
The risk
Clinical risk,
stratification.
clinical risk stratification.
Yes, sir.
So low, intermediate, and high risk. So there,
Yes, sir.
and also, and the last part also, maybe I will miss that there was some issue with the connection. Have you discussed the dynamic risk stratification?
Yes, sir. The post-treatment dynamic risk stratification. Yes, sir.
Dr. Sandipta, can you hear me?
Yes, sir.
Okay. So what actually is a dynamic risk stratification? You said you have
So,
described what actually it is.
so dynamic risk stratification is actually the response to treatment as well as the course of the disease after treatment. So these two variables affect the outcome. So if initially a patient has been stratified as an ATA low risk and subsequently the patient develops certain clinical features or biochemical features which such as a rising TG titer, so the patient does not remain in the low risk in the same low risk. So it has to be dynamically modified and upstaged into an intermediate or high risk. So
To know the concept, I'll just sum it up. So there is a static risk which is defined by the factors which before the treatment. Like AGCC is a static system. You classify that this is T, N, and M, which is given by the AGCC. And this
yes,
is a static risk stratification system. AGs, AMEs, all these are static risk stratification systems. But when you combine the initial risk stratification with how the individual responds to the treatment, there are two
yes, sir.
components in the dynamic risk stratification. First is this, the disease stage, the static risk, which is defined by the TNM classification. And when you combine it with the individual response to treatment, and then you extend it over a period of time, then it is
Yes.
called as a dynamic risk stratification system. At each follow-up of the patient, you should be able to classify the patient into one of these categories, which you have said, depending on the imaging modalities, imaging available, the thyroglobulin level available, clinical examination. So you should be able to give us risk stratification at every follow-up to these patients. This is how the dynamic risk stratification works.
Also,
Yes.
you have told it's the reverse way. Usually, what happens that the higher risk patient comes to the lower risk, not the lower risk goes to the higher risk. Most of the time, it happens.
And why do we need it in thyroid particularly? We don't have any such risk stratification system for, say, oral cancer or other mucosal head and neck cancer. What is the reason?
Sir, because thyroid cancers, especially the differentiated thyroid cancers, have a good prognosis. So such an intensive follow-up or and treatment may not have to be continued for such long periods, and the patient might have to be de-intensified based on the responses.
Okay. They have a very good outcome and the patient lives for a long period of time as compared to the other mucosal
Yes, sir.
squamous head and neck cancers,
Yes,
where
so we
the
usually have a 10-year survival, we say in case of thyroid.
in other
In
cancers, in other head and neck cancers, the recurrence is parallel to the mortality. That if you are able to predict recurrence, you are able to predict the mortality in these cases. And goal of all cancer treatments is to increase the overall survival, right? But in
Yes.
thyroid, the recurrence does not parallel to the mortality because these patients live for a long period of time even after developing the recurrences. So this is the underlying thought process that you need to stratify these patients because they are, even after recurrence, they'll live for a long period of time and you will be able to follow them up and then you will be able to risk stratify these patients at every follow-up visit. So this is all about the dynamic component. This is what is dynamic. You must
Yes.
know the philosophy of dynamic risk stratification.
Sudipta, what is the treatment for microcarcinoma or incidentaloma?
Sir, in thyroid incidentalomas, which are usually detected on imaging modalities like PET, it depends whether it's a diffuse uptake or it is a focal uptake. If diffuse uptake would usually mean a more benign inflammatory pathology like a thyroiditis, or but in case it's a focal uptake, we have to see the size and the characteristics of that nodule. Usually, a focal uptake on PET is a malignant disease. There are high chances of malignancy, around 30 to 40%. So it has to be further evaluated.
How will you evaluate that?
Sir, we will evaluate as in case of a usual solitary thyroid nodule uh, in terms of serum TSH, beginning with the TSH with an ultrasound, look at the ultrasound characteristics, and then do a guided FNSE to look at the cytology, and then grade it according to the Bethesda classification.
And what about the microcarcinoma?
Microcarcinomas are usually thyroid cancers less than 1 centimeters in size, and usually, according to the literature, as per the paper by Ito et al., the papillary microcarcinoma usually carries a very good prognosis. It is a low risk category, so it can be followed up. So a surveillance protocol has been recommended for papillary microcarcinomas.
So which microcarcinoma you will treat?
So microcarcinomas which are having aggressive features
But
such as
you
those.
are not you are, so if it is a less than a centimeter, you are not going to do even FNAC. And when will you do the FNAC for that? If it is a sub-centimetric nodule, will you do the FNAC for sub-centimetric nodule or not?
Yes, we will do so. If it is a PET incidentaloma, if the patient has a history of childhood irradiation or a family history of differentiated thyroid carcinoma, these are all aggressive features. And even if the nodule is less than 1 centimeter, it has to be worked up.
And any location is important.
Locations such as posteriorly based nodules, which are closer to the trachea and tracheoesophageal groove near the recurrent laryngeal nerve, those lesions are to be worked up, sir.
Why?
So, because these being in close proximity to vital structures have more propensity to invade these structures if they obtain any
Even if they
invasiveness.
are small. Yes. Yes. Okay. I think you have covered a lot of things, and I think we are not talking about the Bethesda and all. That is the next part. It will be covered. Um, and Dr. Vipin, anything else?
Yeah, I just want to add one thing. All the nodules in the thyroid are not the same. The nodules which are located anteriorly can be washed
Dr.
easily
Vipin?
by the patient as well as. Can you hear me? So
Yes.
Yeah.
so the nodules which are anteriorly located can be easily watched by the patient, or they're easy to work up or easy to follow up on the serial ultrasonography. But vis-a-vis the nodules which are located posteriorly, which she just said. And when do you decide? And secondly, I wish to add is that just wait and watch or surveillance of papillary thyroid microcarcinoma is still not a standard of the treatment. All these patients, they need to be under a strict surveillance program, or they need to be under a structured surveillance program to qualify the observation. You simply cannot say a patient, okay, you have a cancer in the thyroid, and then you go home and come to me after a few weeks. It has to be a structured surveillance program.
And Sudipta, what about the paratracheal neck dissection? When you will do the paratracheal neck dissection? I think you have covered, but just I am asking you.
Yes, sir. If the central compartment neck nodes are more than 8 millimeters in the short axis diameter, then a paratracheal nodal clearance needs to be done, sir.
How will you come to know that?
Sir, by cross-sectional imaging, we can get to know about
Very
it, sir.
difficult. Very difficult.
Or and intraoperatively, examination also carries value. So intraoperatively, if we find significant nodes in the paratracheal region, that would also uh, be cleared, sir.
You will clear or you will do the frozen section?
We will go for a frozen section, sir, preferably if available, sir.
And when you will do the electively paratracheal neck dissection?
Electively, paratracheal neck dissection would be done if there are clinico-radiologically apparent nodes, sir.
So in all aggressive tumor, aggressive pathology like tau cell or columnar cell, and also if it is a T4 kind of lesion in the thyroid, even if the paratracheal nodes are not looking involved, you should go ahead with doing a paratracheal neck dissection in those cases.
Yes.
It is not a strong recommendation, but it is a recommendation. The other thing is any location of the thyroid nodule which has a more propensity to be involved the paratracheal lymph nodes.
And also when you are doing a lateral compartment neck dissection, so irrespective if you find the lymph nodes in the central compartment, you must do a central compartment neck dissection when you're doing a lateral.
Yes.
So location is like if it is a ischemic nodule, it has a more propensity to develop paratracheal neck nodes, and even if they are not looking involved on the scans, and you should look for it. You should inspect paratracheal neck dissection definitely. Many people do the paratracheal neck dissection when there is a ischemic nodule. Many inspect it, but you have to look for the paratracheal in those cases.
Yes, sir.
So why don't we do it in all the cases? Why don't we clear the central compartment in most of the cases? Like, what are the complications? Let me get to the point. What are the complications of central compartment neck dissection?
Sir, the most important complication is the risk of hypoparathyroidism.
Okay. And other obviously is the injury to the recurrent laryngeal nerve, which is traversing through the central compartment.
Yes, sir.
How you identify the parathyroids during operation?
Sir, the parathyroids are usually identified according to its disposition. The superior parathyroids come in a more ventral plane than the recurrent laryngeal nerve and the inferior parathyroids and their relationship to the recurrent laryngeal nerve. And secondly is by their color. They are usually tan colored, and it has a capsule, and it can be differentiated from the surrounding fat by the sliding sign.
Okay. So it's
Anything,
end of the
anything
procedure. Anything else?
confirmatory?
Yes. Can you do some tests to identify also, and um,
If
if it
if they are detached, then the float or sink test can be done.
okay?
Usually a fat would float and a parathyroid would sink.
So do you do any confirmatory test before you actually reimplant these parathyroids?
A frozen section can be done. It can be confirmed on a frozen section, and then it can be reimplanted into either the sternocleidomastoid or the brachioradialis.
It can be or it should be.
Uh, if it is in a malignancy case, if it is free of tumor, then we should be reimplanting them.
We are talking about malignancy. Okay. So so how you reimplant it?
We usually mesh it into fine pieces and then inject it into a pocket into of the sternocleidomastoid, and make sure that the hemostasis is adequately achieved in the pocket, in that pocket that in which we are reimplanting.
Yes.
Why do you mash it? Why do you cut it into small pieces? Because you want to increase the surface area, and the surface area directly translates into the vascularity, which translates into the viability of the parathyroid tissue. So you want it to be very small so that they can easily get vascularized. That is the reason you want.
Yes.
So how you treat the post of hypocalcemia? Hello, can you hear me?
Hello.
Can you hear me?
Sorry, sir, I could not follow your question. There was an
So how you treat post of hypocalcemia?
So post of hypocalcemia, we would monitor the patient for signs and symptoms of hypocalcemia, which would include tingling and numbness in the extremities, and signs such as Vogt's sign or carpopedal spasm, and look for the lab values of calcium. And if there are presence of signs and symptoms of hypocalcemia or the lab values of calcium less than 8, then injection calcium gluconate needs to be administered.
What is less than 8 is how you calculate the calcium value.
The corrected
If you do
calcium
the
value need,
okay,
sorry,
so it is to be corrected calcium value, or it has to be ionized calcium. Uh, so 8 is the, I mean, this is maybe your protocol from the department, but 8 is not a, uh, it's like a cutoff value always. You have to correlate with the sign and symptom also.
yes, sir.
So what you do? You do oral calcium to the patient.
For signs and symptoms of calcium, we use the injection calcium gluconate.
Okay. So you start injection gluconate or oral calcium also.
Yes, sir.
Both or only one?
Sir, injection calcium gluconate.
Not oral calcium.
If there are signs and symptoms, then we start on injection calcium gluconate.
But you should start the oral calcium also on the same time, because it will take little time for oral calcium to take over. It takes around 72 hours. By that time, the calcium gluconate will work, because temporary hypocalcemia is happening. Patient and sign and symptom, the patient will need the calcium correction for 3-4 weeks, not for the 3-4 days. So you have to start both the things together, the patient and sign of symptom of hypocalcemia.
Yes.
Any more question, Dr. Saurabh, Dr. Vipin? Or otherwise we can move on to the next session.
Yeah, I think we should move on. We are already here.
Yeah, we should. You've discussed
Actually,
most of the things.
yeah. And I would request both of you to be online and participate in the next case presentations also. And we also kept a question answer session in the end. So that would be, we will be needing you there as well.
Sure.
Sure.
So for the next session, I would like to invite Dr. Akhil to please start with the case presentation. Dr. Akhil is a oncosurgery resident in Max Hospital, Vaishali.
Good evening, everyone. I'm Dr. Akhil from Max Vaishali Hospital, surgical oncology resident. I'm presenting a case of a 75-year-old female who is a resident of Noida. She's a homemaker. She
37
presented
years,
with
not 75, 37
so
years.
37. Yes, sir, 37. She presented with the complaints of swelling on right side of neck for 3 to 4 weeks. Patient was apparently well for 3 to weeks back when she started noticing a single painless swelling on right side of neck, initially small in size and gradually progressing to its present size of approximately 2 into 2 centimeter. There was no history of fever, difficulty in breathing, swallowing, facial edema, hoarseness of voice, symptoms suggestive of hyperthyroidism, cough, chest pain, hemoptysis, any bone pain, weight loss, or loss of appetite. This patient had a history of ovarian cystectomy 10 years back. There was no history of any comorbidities such as diabetes, hypertension, or tuberculosis. There's no history of similar complaints in the past, and there's no history of radiation exposure. Personal history, patient takes a mixed diet and her appetite is normal. She has unaltered sleep. Her bladder and bowel habits are normal. Menstrual history, she has a regular 28-day cycle with 4 days of menstruation. She attained Menarche at the age of 14 years. And she has
Dr.
one
Akhil,
life. Yes, ma'am.
you can skip the negative finding and just tell us the positive finding if you have any.
Sure, ma'am. Sure.
And you, you
on
describe.
on local exam. I'm sorry, I don't have the photograph, pre-op photograph of the patient. On local examination, on inspection, there was a 3 into 2 centimeter single overt swelling on right side of neck in the area of right thyroid lobe, which move with deglutition and does not move with protrusion of tongue. Overlying skin is normal with no scar, sinus, dilated veins, or visible pulsations. There's no other visible swelling in the neck. On palpation, there's no local rise of temperature, and there's a single non-tender 3 into 2 centimeter swelling on right side of neck with well-defined margins, smooth surface, firm consistency, extending from right paramedian region anteriorly to sternocleidomastoid posteriorly, and 1 centimeter below thyroid notch superiorly to 2 centimeter above sternal notch inferiorly. Trachea is midline. There's no normal carotid pulsations are normal, and there's no cervical lymphadenopathy. On auscultation, no bruit were heard, and the rest of the systemic examination was normal. So to summarize, this is a 37-year-old clinically euthyroid female presented with 3 into 2 centimeter painless right side well-defined firm thyroid nodule for 3 to 4 weeks duration without any retrosternal extension, without any compression features, and no cervical lymphadenopathy.
Dr. Garima and Dr. Ankur, I invite both of you to participate in the discussion for this patient. And first, Dr. Akhil, tell me what is, on the basis of history and examination, what is your
Yes,
diagnosis or differential diagnosis, I would say?
It's a right solitary thyroid nodule, which needs to be evaluated further.
Differential diagnosis? What?
It could be a differentiated thyroid cancer.
And can it be a benign nodule?
Yes, ma'am. It can be a benign nodule.
So what are the high-risk features? Do you have any high-risk feature which points toward malignancy in your case?
No, ma'am.
Okay. And otherwise, what are the high-risk features in any nodule which makes it more suspicious for to be a malignant?
Hoarseness of voice or any feature of dysphagia or
And?
any cervical lymphadenopathy or distant meds.
Examination findings?
On examination, there would be a hard nodule, or they could hard nodule or
Any family history? You're aware of
no,
any
ma'am.
family
No,
association?
there
Not
is
with
no
our
family
patient,
history.
in general. Are there any familial syndromes or any family history which could be significant?
Yes, ma'am. Familial thyroid cancer, and there could be syndromes like Cowden syndrome, MEN2, and FAB syndrome.
Okay. Okay. So how will you investigate it further?
I would like to first do the blood investigations, including routine blood investigation along with the thyroid function tests.
Suppose the TSH is low.
Yes, ma'am.
Then?
Then if the TSH is low, then radioactive iodine uptake scan should be done
To see what?
identify whether there is any hyperfunctioning, isofunctioning, or a hypofunction nodule.
Okay. Okay. And
Uh,
suppose thyroid, like it is in your case, what would be the next investigation?
Sorry, ma'am.
So suppose it is euthyroid, TSH is normal or low.
Yes, ma'am.
You proceed.
Yes, ma'am.
What the next?
Then we will do the ultrasound neck to identify that the lump is actually a thyroid nodule, and the see other features and the composition, shape, margins, echogenicity.
What are the high-risk features which point towards malignancy? 1, 2, 3, 4, 5.
Yes, ma'am. Microcalcifications. Shape would be taller than wide. It could be a hypoechoic, irregular margins.
Heterogeneous and
Yes, ma'am.
peripheral.
Yes.
Okay. Okay. And what do you mean by hypoechogenicity? What exactly it is? When do you call it hypoechogenicity? What is isoechoic? What is hyperechoic?
Means that the echogenicity, it is in comparison with the rest of the thyroid gland.
So you either compare it with the opposite lobe or you compare it with the adjacent sternocleidomastoid and you see the echogenicity. If it is normal or high, it is mostly likely to be benign. If it is hypo, then it's slight, kind of a pointer towards it. Solid nodule, basically.
Okay.
Okay. Any classification system you're aware of for radiological risk stratification?
Thyroid's category.
Name, yeah.
TR1.
One is
Hello.
Hello. Yes, yes.
Am I audible, ma'am? Yeah.
Yes, yes. Pretty much.
Yes. Thyroid's category. This TR1, 2, 3, 4, and 5. It is divided into 5 categories and given points according to the characters of the ultrasound, like composition, shape, margin, echogenic foci, and echogenicity.
What is thyroid's ACR? Have you ever heard the term thyroid's ACR?
Yes, ma'am.
So basically, earlier thyroid classification used to be there, which used to take into account these factors and just graded into 1, 2, 3, 4, 5. Now we use the thyroid ACR, where the American system is also clubbed. So there we give the scoring that is considered to be more objective and more, accurate. Okay. Next step. So suppose it is thyroid 3 or 4. What will you do next?
Then, ma'am, it depends on the size of the region. In this case, it is more than 2 centimeters.
Just be specific.
Yes.
Your patient
Yes,
I'm
ma'am.
asking.
Ma'am, we will do the FNAC, ultrasound guided FNAC.
Why not palpation based? It is 3 centimeter. You can do.
Yes, ma'am, but there might be some cystic areas, and we want to be specific in taking the sample.
Okay. Suppose even if it is solid, you have done ultrasound earlier. At that time, FNC patient comes to you with the report, and then you see it is a solid nodule and no cystic component. Then can you do palpation based, or you will still go for ultrasound guided FNC?
Ma'am, ultrasound guided FNAC has lower negative lower negative rates of coming out to be.
Study?
Ma'am?
Is there any study which is supporting your?
No, I don't know, ma'am.
So there is actually a systemic review which was done, published in BMC 2008, and then they compared both the methods. They compared the studies which have looked at both the methods, and it was found that ultrasound guided FNAC is more accurate and there are less chances of inadequate samples.
Yes.
Okay, so how do you do FNAC of the thyroid?
Ma'am, we take 26 gauge needle. And at least 6 samples should be taken with at least 10 epithelial cells in each cluster of the sample.
Dr. Garima, would you like to comment on his answer?
10 epithelial cells is what the needle he said is fine. What we try to do is you should be very specific about the position that you're hitting the patient in the right lesion. And when you do it, we usually do a diff quick to check whether the cellularity is sufficient or not. So if you've hit the lesion, I'm not saying for going for a perfect diagnosis just on the diff quick, but an immediate staining is done just to check the cellularity is sufficient. So if you've hit the thyroid lesion, you will have at least some follicular epithelial cells which are present. So whether it is malignant, not malignant, or whatever it is, will come with the final stains that we do. Different stains, but at least hitting the lesion and checking it on the diff quick what sufficient cellularity is what is must for, so that you don't go for inadequacy or repeating the sample.
Okay.
Define adequate smear, Dr. Akhil.
Ma'am, 6 clusters each of at least 10 epithelial cells on one slide.
Okay, so what was the FNAC in your patient?
The FNAC came out to be, ma'am, Bethesda was consistent with papillary thyroid carcinoma, consistent category 6.
Okay. So can you just enumerate all the categories, Bethesda?
Yes, ma'am. Non-diagnostic. First is non-diagnostic. Second, benign. Third is atypia of undetermined significance. 4 is follicular neoplasm. 5 is suspicion for malignancy, and 6th is malignancy.
Suppose your patient comes, Bethesda comes as Bethesda 3.
Yes, ma'am.
You would do what would be your next step?
We can repeat FNA or with along with molecular testing.
Okay. What are the molecular tests which you will use?
BRAF 600V.
Have you ever heard of rule in and rule out test?
Ma'am?
Dr. Garima, would you like to take this question?
Yeah, so the molecular testing that he's saying is not very prevalent in Indian scenario per se. BRAF V600E that he's saying is basically we have the immunohistochemistry also available for the same. But doing the immunohistochemistry on cytology is again a very difficult scenario, and the positivity is very bad. And going in for a molecular testing, usually the patients that we are facing are not very comfortable going in for the molecular thing. So what usually is preferred is either you go in for a repeat FNAC, or if clinically the lesion is very suspicious, then the surgeon usually proceeds with a lobectomy or a hemithyroidectomy, depending upon the size of the lesion.
So molecular testing here, it is not very popular testing, and even abroad as well, because of the high cost associated with it. But
Absolutely.
as a resident, you must be aware of all the tests. So we basically have one rule in test and one is rule out test. So rule in is basically if suppose we are suspecting that this is most likely to be cancer, then we do rule in testing, in which we have multiple gene mutation panel like BRAF and RAS mutations, etc., etc. Rule out is basically our diagnosis is more in favor of benign. Then we do rule out testing. Okay, so but you must read about these molecular testing and status in thyroid cancer. Okay,
Yes.
so you have level 6. What are the classical papillary features? I mean, I am asking on FNAC. Suppose like it is type 6, right? So what are the classical papillary carcinoma features on smear?
Sorry, ma'am.
Okay, no problem. So it's mentioned nuclear crowding, overlapping, grooving. Dr. Garima, just
So
for the benefit.
usually the papillary carcinoma features are very typical, and we look for all the nuclear features. If you are lucky, you will get all the nuclear features, but what are the features that we typically look for is nuclear crowding and overlapping that is seen. Apart from that, we have nuclear inclusions, which are more appreciated on the papinocular stain or the pap stain and not better appreciated on GIMSA. And the nuclear grooving is also seen. So if we get all these features, then we are pretty sure that it is a papillary carcinoma thyroid only, and we can give it out as Bethesda category 6 or malignant for papillary carcinoma thyroid. Sometimes if it is a follicular variant of papillary, we should ideally get the papillary features, but sometimes it is a miss. So we report it as suspicious for malignancy or suspicious for papillary carcinoma thyroid. So the 5 or 6 features, that is nuclear overlapping, nuclear crowding, nuclear grooving, nuclear inclusions, and typical papillae also can be seen in the cytological smears at times.
So moving on, treatment of this patient.
We did, ma'am, total thyroidectomy.
Okay. Why did you do total thyroidectomy and did not do a hemithyroidectomy?
Ma'am, because there was on ultrasound, there was a, nodule on the opposite lobe also on the left side.
What was the size
So
of that lobe?
it was 8 into 5 mm.
Okay. So did you do FNAC from the other?
From the right side, ma'am. From the it was actually the ultrasound and FNC were done outside only,
Was this the
but
sole
we
reason?
got this slide reviewed at our hospital also,
Hmm.
ma'am.
So was this nodule in the other was suspected of malignancy, or you just did it because it was there and you didn't want to leave behind it?
Ma'am, it was a hypoechoic nodular lesion, and the other nodule had come as a papillary. So, and there is high propensity for multifocal disease in papillary thyroid carcinoma. So, that's why we went for total thyroidectomy, ma'am.
Yeah, that if you have a nodule, even if it is, if it is sub-centimeter, you should do total. But this recently has been challenged by a publication of an article recently published where they have studied almost 700 patients where they had
Yeah.
nodule in the contralateral lobe. Some of them, majority were of course operated, and many of them were observed as well. And they found that there was not much difference in the growth when they have followed. They have followed it for 5 years, and the risk of malignancy in those nodule contralateral, which were sub-centimeter, was very low. It's 2.9% also. So that is one, latest thing which not all nodule, if it is just showing nodule in the opposite, that should not be the sole criteria. Though it in this case, it was slightly higher, 8 millimeters. So yes, it could be multifocal disease. Other things, suppose there was nothing in the opposite lobe, would you still do total or would you do hemi, or how would you decide?
Ma'am, hemi only, ma'am, because there's no high risk features other
And
than in this.
can you quote any literature for it?
No, ma'am.
So that you must read.
Yes,
So
ma'am.
literature, what is in favor of hemithyroidectomy vis-a-vis total thyroidectomy? That is very important question. Basically, we have Carl Bilimoria, which is in favor of total thyroidectomy, and then that used to be the classical surgery. Then we have Nixon, Adam, Anderson, and many authors which kind of demonstrated that hemithyroidectomy is sufficient. That is must read. Okay. Anyway, suppose we have done total thyroidectomy for this patient. Now, how would
Yes,
you? Do you have histopathology report with you?
yes,
Quickly.
yes, ma'am. Yes, ma'am. This is the tumors. It was a multifocal tumor.
You don't have to read it. You must have read it. You just tell me what are the high-risk feature in it, which warrants it for a case for radioactive iodine therapy, or you would just observe whether this is which category.
This is 80 intermediate risk because of the microinvasion in the strap muscles.
Okay. So what would you like to do?
Ma'am, go for in this case, radioactive iodine should be given, low dose.
Okay. How will you prepare this patient for radioactive iodine therapy?
Ma'am, TSH, thyroid hormone should be withdrawn for at least.
Patient is in the ward. Okay, histopathology report has come. Today is post-op day 5. What instruction you will give to the patient so that, when he sees the nuclear medicine expert, then, how will you go ahead? You'll just discharge the patient, you'll start altroxin, you will not start altroxin. What will you do? Anyway, no problem. Dr. Ankur, would you please elaborate on this part?
Yeah, so this is actually very important stage on the means, as you just mentioned, post-operative day 5, the histopathology report is out and you are just about to discharge the patient. So our recommendations to all the surgical oncologists is that you ask the patient to meet the nuclear medicine physician at the time of discharge. So this is done actually for better planning of his further radioiodine treatment. There was an initial view that the radioiodine therapy needs to be given at around 5 to 6 weeks post-operatively. But right now, we actually prefer doing it after 4 weeks. I mean, 3 to 4 weeks. This is done so as to avoid any kind of hypothyroid symptoms, which ultimately are problematic for the patients. So patients meeting us after 4 to 5 weeks is actually causing a lot of delays, because we have to procure radioiodine also, which is not readily available at any radioiodine, any nuclear medicine center, and it has to be procured either from outside, imported from outside, or from BARC Mumbai. So that takes a bit of time, means around 7 to 10 days also, sometimes it is required. So the first meeting we prefer is at the time of discharge. The other thing is we give instructions related to their iodine precautions. The stable iodine should be avoided in the diet, or should be kept at a very low level. So low iodine diet is which is required for the patients. So we give them the list of precautions to be taken, such as they have to avoid any kind of seafoods, they have to avoid iodized salt, they should avoid multivitamin supplements, such as even supplements such as Bonvita or Horlicks, which may contain some amounts of iodine. Then they have to avoid any kind of betadine exposure, betadine creams or gargles. Many times we come across patients who are not operated in surgical oncology setups, and they are being treated at smaller nursing homes, and they are using these betadine lotions and creams for their scar sites. So that actually this defers the therapy, or it causes hindrance in the uptakes of radioiodine.
Great.
Dr.
Thank
Ankur,
you.
I have a question. Dr. Shilpi, may I ask a question, Dr.
Yeah.
Ankur, one question? So, Dr. Ankur, most of my patients, their TSH goes beyond 30, maybe around second week, 2 weeks, 14 days from the surgery. Is there any contraindication to give if the RAI is indicated to give it at 2 weeks?
No, sir, no contraindication. Actually, the cutoff level is 30. So we actually ask our patients to do the first TSH after 3 weeks post-operatively. So usually most of the patients, they attain the level of 30 at that time, and we proceed with further workup with the whole body iodine scan or serum thyroglobulin measurements.
So I rarely see my patient go below 30 after 2 weeks. I mean, they cross 30 at 2 weeks, most of them, 95% of patients. So I just do at 2 weeks and I send them to, if it is indicated the radioiodine, I send them to nuclear medicine. Actually,
so this has happened actually with the better surgical outcomes also. Means the smaller the residual tissue is left in the neck after surgery, the better chances is that the TSH will rise more than 30 in even 2 weeks time.
Another thing is, but suppose even if your TSH is high, but you also look at the when the CT scan was done.
Yes.
So
yeah,
if we
yeah.
have, I mean, that period should be 4 weeks, right?
That period must be 4 weeks. Yes. So we actually always say that if a CT scan without contrast can be avoided pre-operatively, then it is better for the patients.
Never be avoided. I mean, CT scan with contrast only. That's the new teaching. Because otherwise, without contrast, we don't get details. So we always do contrast enhanced, but we by the time, so that's what we say. But sometimes when patient is admitted, and we have done very recently, we do surgery, and but still you wait for 4 weeks, right? If I'm not wrong.
Yes.
And also say 6 weeks. So it is 6 weeks or 4 weeks?
Actually, IV contrast has a high amounts of iodine. So means the recommended practices are you should wait for at least 6 weeks. But then the problem is that the patients will become very hypothyroid, and their TSH rises to more than even 200 and 150. So that is a problem actually for very elderly patients. We have come across one patient who landed up in hypothyroid coma on the day of therapy.
There is a publication also
I start the thyroxine in those cases and stop after one surgery for 2 weeks, and then we give radioiodine. So I start the thyroxine in those cases where we have
For
done a
very elderly
CCT.
patients, yes, we can do, or if the CT scans
Yes.
have been done very recently, yes. And many times we come across
And second
patients
thing,
who,
I just so one more question: do you use the gamma camera to see how much percentage of thyroid is left? That aims do it. No other institute do it, but do you recommend it or not?
we recommend it because the practice says that if the neck uptake is more than 20%, then you have to resend the patient back for surgery because there is a large amount of residual remnant left, which may not be addressed by radioiodine actually. But nowadays we don't come across such scenarios.
RMC it is done, Saurabh, not the
Yeah,
same.
yeah. We do it. We do it TMH and RMC, and there the
Yeah,
cutoff
yeah.
is
TMC.
15%,
No,
not
not
20%.
I am speaking
It's
about the
15%
Delhi
RMC.
for the Delhi.
Okay.
Oh,
I am talking about the Delhi.
okay. No, Dr. Ankur must be doing it.
I'm
Yeah,
not
yeah.
getting the question, sorry.
So Dr. Saurabh is saying that at some center, they don't do this percentage.
Yes,
Uh,
yes.
Look at the residual.
So actually, the exact calculation of percentages require a thyroid probe, which is not present in most of the nuclear medicine centers. We also do this neck uptake calculation using our gamma camera, which is not the ideal way, but it gives us a very good idea about the neck residual tissue. Secondly, we can always correlate it with the visual thing which we see on the scans.
Just one more thing, and I would like to
I
have
have-
your also in this. Dr. Sandipta, in her presentation, I saw that she mentioned somewhere low iodine diet for 1 to 2 weeks. Why it was 1 to 2 weeks, I did not understand. It should be continued for till the time we do the
The
scan.
therapies are over, yes, but the minimum is 2 weeks at least.
Yeah, that is the
The
minimum.
ATA says a minimum period of 2 weeks.
And Dr. Akhil, are you aware of a term thyroid
Thyroid?
stunning?
Yes, ma'am. Before giving the radioactive iodine ablation therapy, if radioactive iodine scan is done, there may be tumor stunning, and the iodine uptake may be less than actually required.
Dr. Ankur? Any
Yeah,
comment?
so stunning is a phenomena, as Dr. Akhil has rightly mentioned, that iodine whole body scans can sometimes lead to stunning, which actually hamper their further uptake of the radioiodine during therapy part. But to avoid that, we recommend going for a low dose of iodine during the iodine scans, that is less than 2 millicurie. Less than 3 millicurie is actually recommended. We usually do the scans with 1.5 millicurie for such patients. And secondly is radioiodine therapy should be given within 3-4 days of the radioiodine scans. This is actually again ideal practice. Not always possible because we have to procure the iodine, which takes around 6 to 7 days at least. So we prefer to do it within 6-7 days time.
Okay.
This avoids
I
stunning in
had
most of our
I
patients.
had a question for Dr. Akhil. Dr. Akhil, you told that it is a papillary and you did went in for a total thyroidectomy.
Yes,
Was neck dissection not done or neck was not addressed? Because I can see there is just one single lymph node which is
Yes, ma'am.
uninvolved. That
Actually,
is
one lymph node was identified during the surgery, one enlarged lymph node. There was no indication for neck dissection preoperatively, ma'am.
So you did central exploration kind of thing, right?
No,
You did
ma'am.
not,
There was
or
no,
this
ma'am.
was not the thyroid specimen.
Yes, ma'am. It was along with the thyroid specimen. Another lymph node was identified.
Okay. Yes, I think we.
and
Okay. If you have any question, then please go.
no, just
Dr.
a query that the histopathological subtype that has been given in this was papillary thyroid carcinoma infiltrative follicular type, right? So the WHO has now segregated it, and we have another category which is invasive encapsulated follicular variant of papillary thyroid carcinoma. So do you know the difference between the two, or is it just a jumbling up of words that they've done? Any thoughts about that, Dr. Akhil?
Sorry, ma'am.
Sorry, I can't hear you.
You can elaborate, Dr.
Yeah.
Gariman, the benefit
Okay,
of all of
so basically, although the latest WHO classification is a little difficult to comprehend, but it is very descriptive. So they've classified it according to the prognostic behavior of the tumor. So the invasive encapsulated follicular variant is supposed to be behaving like a follicular carcinoma, and the patient might present with distant metastasis in a future time. Whereas a follicular papillary thyroid carcinoma, be it infiltrative follicular type also, will behave typically like a papillary thyroid carcinoma. And another thing that I wanted to say is we had a discussion about the papillary microcarcinomas. So now papillary microcarcinoma also is not a different subtype. According to the latest WH and CAP protocols, we need to subtype it according to whatever is being seen in that microcarcinoma focus also. So that is something that needs to be emphasized because everybody should be clear about that.
carcinoma now, no?
Sorry,
Microcarcinoma
ma'am?
term. Microcarcinoma term also has been kind of
Yes,
erased,
ma'am.
no?
So
term.
basically, it is not a subtype which can be used separately. We need to subtype it whatever type is present in the papillary carcinoma. Absolutely.
Thank you, everyone. Thank you, Dr. Akhil and both the we are now concluding this session, but now please stay tuned for the next case presentation. I would invite Dr. Syed for the same. Dr. Syed, over to you. And I'm sure we'll have more discussion on RAI in our question answer session, if there is any. Dr. Syed? And I also would like to invite Dr. Akshat Malik for this session. Dr. Akshat is a head neck onco surgeon at Max Hospital, Saket, Delhi. And we will be having case discussion on medullary thyroid cancer. Dr. Syed, are you ready with the slide?
Yeah, I think he has shared it.
Okay, great. We can see it now. We can't hear you, Dr. Syed. I think something is wrong with his.
I've spoken to him. He's probably trying to log in again.
Okay, okay. So in the meantime, we can discuss any, if there is any short query on the management of differentiated thyroid cancer.
Dr. Shilpi, I just have one point to make. There was a discussion about ATP Bethesda 3, and then how do you go further, like molecular testing? And so there's just one comment is that when ATP of undetermined significance is there, always go and look back at the thyroids. That what are the chances of suspicion, or what is the extent of suspicion in the radiology, and then take a call after that. This is the only point I wish to emphasize.
Correct, correct. Rightly said. In fact, we also missed, I mean, because of course you can't miss everything. You can't discuss everything, but there are some immunohistochemistry also. Dr. Syed, are you available? So just stop us whenever you are ready. So we
Sayed,
now.
unmute yourself.
Hello. We can view it, but
I think, Sayed, you can probably log in from your mobile also. You can speak through your mobile and present through the computer.
Nidhi, you also have his presentation. Acha, he did not share it with us. Or otherwise, you can just quickly mail us, so we will play from here.
No, but he's not able to speak. That's the main problem.
Oh, that's the problem.
Shilpi, in the meanwhile, how often do you get the molecular testing done? Like for
Never done. It's all in theory. The cost
yes.
is so high. So
The
it
cost
is
is very high. I think in our case, in our
not worth.
Sir,
situation,
I have done it for.
BRAF we have done not for the diagnosis, not to take the decision whether hemithyroidectomy to be done or total thyroidectomy done. For the prognostic point of view, yes, we have done to look for BRAF testing, but not routinely.
I have done for indeterminate nodules. I do them about once in 3 or 4 months, not more frequent than that. And generally, they have not been very helpful. I've never had a positive report till now, which is suggestive of anything. Having said that, you are talking about cost. So currently, sir, there are standard tests which are available through several labs, and even my hospital, they have started their own thyroid genomic panel. So it costs somewhere about 25 to 35,000. That is what it costs. So
then
it is helpful
it's
for patients who are happy to observe and who are just wanting to be reassured that nothing else is going on. Otherwise, I have not really found this to be of much benefit. But someone who is keen not to get operated and you are telling them, then this is just another way to reassure.
in our setup, such a
If
patient
the
would
cost would
typically
have
undergo a hemithyroidectomy. Sorry.
Yeah.
So if the cost would have been low, I would like to do it in all 3 and 4. I mean, why not?
Panel,
If the cost is
I have helped made that panel with the molecular oncology team in our hospital, and
yeah, I
probably
know.
it will start costing around 15 to 25,000. So that's the cheapest I think we can go.
Yeah. But Dr. Akshat, that panel is equivalent to what we have at present, the thyroid sequence panel. It's not actually completely. So that's
What
the
we have
problem.
done is it's mainly we are using rule-in test, all those markers which are there, same we are using here, and of course they need to be validated.
Yeah.
So yeah. Syed, are you ready now?
Yes, sir.
Oh,
Sir, am I audible?
Yeah,
yes.
you are audible. Please present.
We are waiting for you, Dr. Syed.
Sorry, ma'am. Sorry for the technical glitch.
You can present it orally also. I think that is
Verbally
fair. You can
बोल दो,
just send
देखने
us
को
the
तो
findings.
Yes, yes.
Okay, sir.
Clinical examination, ultrasonography very briefly, and then FNA if it has been done. Well, you can present it orally.
Yes, respected faculty, sorry for the technical glitch. I am Dr. Saeed Dawood Qasim. So I will be presenting a case of a patient who visited to our OPD with the thyroid neck swelling. I will be discussing how we proceeded with the evaluation and how the investigations came out and how we.
And just the positive findings in the history and exam, because we are
Okay.
already.
So this is a patient, 45-year-old female, who presented with midline neck swelling on the right side with no features of hypothyroidism, hyperthyroidism, and with no features of locally advanced disease and no features suggestive of systemic disease. So patient was evaluated with USG suggestive of 2 into 2 centimeter thyroid nodule on the right side of the thyroid lobe, with few suspicious cervical lymph nodes on the right side, level 2nd, level 3rd. So USG guide FNAC was done, which was suggestive of batches of 5 medullary carcinoma thyroid. So in view of the findings on the FNA, immunoflow cytometry was run, and it was positive for calcitonin, CA, and chromogranin, and it was negative for TG. So because of the findings, usually it is very rare that such findings come on FNA. So we reassessed the patient. We had a repeat history and examination. There were no features suggestive of clinically no features suggestive of pheochromocytoma, hyperparathyroidism, no history of pruritic skin lesions, no history of constipation, no history suggestive of diarrhea, flushing, wound pains. Subsequently, serum calcitonin and serum CA levels were sent. Serum calcitonin was 50 picograms per ml, with the normal reference lab range in the range of 8 to 12, and serum CA levels were 15 nanograms per ml, with the normal lab reference range less than 3.5. So we also sent DNA analysis from the RET gene DNA analysis from the blood sample, which subsequently came out to be negative for any pathological mutation.
Okay, Dr. Akshat, over to you.
So I will summarize. Our patient was a 45-year-old female who presented with a thyroid nodule on the left lateral thyroid nodule, and clinically there were no neck nodes. On ultrasound there were 2 into 2 centimeter nodule and few suspicious nodes, level 2nd, level 3, and FNA suggestive of Batista 5 medullary carcinoma thyroid, which was confirmed on immunocytochemistry. And there were few suspicious nodes on level 2nd, level 3. RET gene analysis was done, which was negative. And meantime, we also did biochemical evaluation for pheochromo and hyperparathyroidism, which were also negative, and metastatic evaluation with CECT NET. Yes.
Syed, okay.
Enough. We have heard it.
That's fine. So I think in history that is common with the general thyroid history. We can ask more specific questions with regards to workup and further management, I believe. If anyone wants to ask anything regarding history, others also welcome to do that.
Serum calcitonin was done. Sorry.
Yes, ma'am. Serum initially we evaluated as a routine thyroid nodule. Once the findings came out to be medullary carcinoma thyroid, we sent serum calcitonin, serum CEA. Serum calcitonin was 54 picograms per ml, and serum CEA was 15 nanograms per ml.
So, Syed, what is the association of calcitonin with disease burden? Can you elaborate on that?
So the calcitonin has two benefits. One, it is diagnostic, and second, it is associated with the disease burden. Like less than 20, we hardly see any nodal metastasis, and less than 500, we hardly see any metastatic disease. And in patients with less than 500, there is always evidence. Most of the patients have evidence of metastatic disease. And in patients with
Syed, just a minute, Syed. So if there is disease in central compartment, what levels of calcitonin would you expect, and what levels will you expect for lateral compartment disease?
With any central compartment, ipsilateral central compartment, I would expect levels around greater than 20, and with ipsilateral, I would expect greater than 50.
So there's a simple way to go about it: 20, 50, 200, and 500.
Okay.
All right. So 20 is just With 20, more than 20, you will expect ipsilateral central compartment. And then,
Greater than 50.
Yeah. So it's like that. All right. And why would you want to do CA? How would that help you?
CA again, there are some conditions in which calcitonin is falsely raised, or there are still some conditions in which there is medullary carcinoma thyroid, but calcitonin levels are undetectable or they are very low. Like with poorly differentiated medullary carcinoma thyroid, CA levels will still be raised, but calcitonin levels will be low.
So more aggressive variants of medullary CA will have higher CA value. So that in those patients, you can probably do it. So tell me, Sayed, are you happy with just an ultrasound in patients with medullary CA thyroid, or you would prefer doing any other imaging also?
So medullary carcinoma thyroid, they have unlike the differentiated carcinoma thyroid, they have high risk of metastatic disease.
What
So I would
percentage
like to evaluate for
can you tell some percentage? What percentage of nodal metastasis may be there?
In patients with stage 3, stage 4 at presentation, there are around 10% of the patient who present with metastatic disease.
No, this is way higher. It's close to 60, 70, more than 70%, I would say. They would have some nodal metastasis being harbored.
So I am, sir, I am talking about systemic metastatic disease. In patients with
we are talking
the
about
risk
nodal
of nodal
metastasis.
metastasis. So the risk of nodal metastasis in central compartment and ipsilateral lateral compartment is around 70%. But I am talking about systemic metastasis. It is around 10% in stage 3, stage 4.
So you try and be brief in your replies. No need to be so elaborate. All right. Just tell us, what imaging would you prefer? Are you happy with the ultrasound? Yes or no? If no, then what imaging would you prefer for such patients?
So I would further like to evaluate for the systemic disease with CECT neck and CECT chest and triple phase CT abdomen.
Can I ask one question?
Yes, ma'am.
So, Dr. Syed, you mentioned that risk when the calcitonin value is more than 200 or 500, then it
More
is
than
like
500.
Yeah, distant metastasis. But your patient,
Yes,
it is only, then why you are doing it?
This is something we discussed with the patient, but ideally, I would agree with your statement, ma'am, that in patient is less than 500, there are hardly any systemic disease. But because the disease is highly aggressive, so we proceeded with CECT neck, chest, and abdomen.
Even I would do it. I just wanted to know, I mean, what is your philosophy?
What's the reason?
Can't take it as a sacrosanct that 500, then only you will do distant metastatic workup. Medullary cancer, thyroid, you should do distant metastasis workup. And it shows us a likelihood. If it is 500, there will be gross distant metastasis.
Okay.
So bottom line is you don't need to bank completely on the calcitonin level. You need to do CCT neck and thorax upfront for all these patients. You should be considering. Regarding abdomen, you said you would prefer doing a triple phase scan. How would that be helpful? What are you looking for there?
In abdomen, the most commonly I will be looking at liver metastasis. So liver metastases are very well defined on triple phase, either triple phase CT or triple phase MRI. Since I am doing CT, I will do triple phase CT of the abdomen to assess for any hepatic metastasis.
Why can't we just
Sorry, please go ahead.
No, I just wanted to ask him why to do multiple investigation. Why can't we do FDG PET CT for this patient?
Ma'am, FDG PET CT as per its sensitivity is less than the CT and MRI. So it is not recommended in the upfront setting. Its role is only in the recurrent setting in patients with recurrence or in patients with residual disease. In upfront setting, FDG PET or even DOPA PET, it is not recommended.
Dr. Ankur, would you like to comment on it?
Yeah, means no doubt FDG has a lower uptake in medullary CA thyroid, but saying that its sensitivity is even less than CT is not a right statement, because nowadays FDG PET is usually done with contrast enhanced diagnostic quality CT, and many of times we do a triple phase CT also if there is a suspicion of liver lesions. So, and second thing I would like to say is that fluorodopa PET CT scan is showing very good uptake, not that high uptake as we see in aggressive other malignancies, but it is quite good compared to an FDG PET CT scan. So rather than going for multiple CTs of different areas, we can safely ask for a fluorodopa PET CT scan with contrast enhanced CT. So that would be a better option.
Okay, sir.
Availability becomes an issue, I guess, with the DOPA.
Availability is an issue because fluorodopa is not available everywhere, but in Delhi NCR now we are doing these scans since last 3-4 years.
What is the cost of it?
Fluorodopa is around 25,000 whole body fluorodopa PET CT scan.
More or less the FDG PET.
Yes, yes.
You were trying to quote some studies which you are mentioning where they've compared PET with these imaging which you're talking about. They are generally older studies. These guidelines had also come out 7-8 years back. After that, like Dr. Puthi has mentioned, there are several comparative studies which have come out. There's no like there are prospective ones also where they've said that PET or fluora PET is dopa PET is better or as comparable as other things you would look for. So,
Okay,
yeah. All right. And you had mentioned about doing genetic analysis. How was that helpful? You said there's no family history in this patient.
Yes, sir. There was no family history in this patient, but still, I would like to do genetic analysis because sometimes the patient may be our index case, which is more common in men 2B, but it is still seen in men 2A. So they have the de novo mutations in the germline instead of inherited mutation. This can be our index case. So it is important with respect to screening of the relatives who are at risk.
Yes, so our patient may be an index case, and it will help us in counseling the relatives and people next of kin for the patients. All right, and which are the high risk mutations you are looking for?
Sir,
Like with meant to B, meant to A, what are the mutations which happen? Are you aware of them?
In ATA stratifies these categories as per the genotype into the highest risk, high risk, and moderate risk. Highest risk is usually meant to be with M918T mutation, and high risk is meant to A with meant to A C347. Sorry, I do not remember exactly. It is I think C347 mutation and A338 mutation.
883 is also there. So there are three, 4 of these which come in intermediate category. All right. How do they impact your management? Sorry, Dr. Shilpi, please go ahead.
Since we are discussing RET, so how do you do this RET testing? Are there any different types?
Ma'am, there are two ways of doing RET gene testing. Some people prefer analysis of whole of the genome, and some prefer to do them to send the mutational analysis of only the codons which are most commonly involved, like exons which are most commonly involved, like 10, 13, 14, 15, 16.
My question was, would you do it in blood or will you do it on tumor?
No, I will do it in blood because I am checking for genetic mutations. I'm not checking for somatic mutations. RET mutations or any other mutation seen in the somatic test, they won't have any treatment implications, or they do not have any implication with respect to the screening of the family.
Dr. Garima, would you like to have a comment on it? Can you just clarify that what is the role of somatic mutation testing from the tumor in current era?
So medullary, as you said, ma'am, correctly, we'll go for the genetic mutation because we are looking for a familial role, basically, and red mutations are commonly seen, and along with red mutations, we also see RAS mutation or PIK3 mutations. Even MAP kinase mutations can be seen in cases of medullary. Also, I would like to just add one thing that in some of the cases of familial syndromic cases of medullary, we also it is also advocated for prophylactic thyroidectomies in order to detect tumors which might not be presenting. So I just wanted a clarification from your end. Is it done because medullary carcinomas are not very routinely encountered because the incidence is per se low. So prophylactic thyroidectomies are this is what WHO recommends that one should go for prophylactic thyroidectomies in cases of familial syndromic cases of medullary.
Also follow the same. If the mutation is highest risk mutation and if it is it needs a prophylactic thyroidectomy in relatives, then we do it. If it's no mutations, then we follow it up with the calcitonin and we follow that. But if it is high risk, then we do it.
Sayyed, what's the age cutoff for doing prophylactic thyroidectomy in high risk?
Sir, sir, I would like to answer it like this. I would first risk stratify my patients, and I would look for the genetic testing. I will first confirm whether the family members are carrying the
Sayyed,
same.
please be brief and to the point. We're asking you a specific question. If there's a high risk mutation which is seen in the patient, or you're aware that there's a family history and the
Okay, sir.
person is having or that child is having, what is the age cutoff you use for these patients?
So I would, in patients with MEN 2B, ideally prophylactic thyroidectomy should be done with less than 1 year. In patients with high risk category, it should be done less than 5 years. And in patients with moderate risk, it is best to follow up the patients with serum calcitonin and CA level.
Would you be addressing central compartment in these patients?
In patients, in infants, if I am doing total thyroidectomy less than 1 year, it is better not to address the central compartment because the risk of permanent hypoparathyroidism is very high because parathyroid glands are very difficult to identify in such patients. So if I am doing surgery in infants, I won't address the central compartment unless they are clinically involved.
And for pheochromocytoma, when do you look for it and what's the age cutoff for operating upon it?
So before doing any usually the pheochromas they occur in after third or fourth decade. Before doing any thyroidectomy in patients, I would look for pheochromocytoma. The diagnosis is made biochemically and localization can be made with CT.
Yes, but you are looking for it in all patients?
Yes, I am looking
for it in all.
Yes, sir.
One, you have looked at it in imaging. What other methodology do you use for screening for pheo?
So for pheo diagnosis is always biochemical, and imaging is only for localization. Biochemical diagnosis is with the help of serum metanephrines or 24-hour urinary metanephrines.
Okay. So 24-hour urinary metanephrine may at times be cumbersome, patient not too happy. Serum metanephrines are found to be sensitive enough to detect it. All right. Going back to our case, so how would you like to manage this patient? What treatment would you do for him?
Sir, I would like to proceed with total thyroidectomy, and I would also like to address the central compartment, ipsilateral lateral compartment, as well as the contralateral compartment.
No, you said total thyroidectomy, bilateral central compartment.
Yes, sir. Total thyroidectomy, central compartment, bilateral central compartment. ipsilateral lateral compartment as well as the contralateral lateral compartment.
Okay. By lateral compartment, what levels do you mean?
Level 2 to 5 ipsilateral and level 2 to 4 contralateral.
So 2 to 5 you only do if there's a positive node out there. If there's any clinical radiological sign that there is a positive node, only then you will do 2 to 5. Otherwise, you can just do 2 to 4 and no need to address level 5 for these patients.
There were clinically suspicious nodes, level 2, level 3, although clinically they were not palpable, but on ultrasound there were suspicious features of level 2, level 3 involvement.
What features suggest a suspicious node on ultrasound?
So loss of the normal architecture of the node, size of the node, loss of the size of the node, loss of the shape of the node, loss of the fatty hilum,
loss of
and
fatty
loss
hilum.
of corticomedullary differentiation,
So
and
which
extrathyroidal extension.
extranodal extension. Yeah. Okay. And roundish nodes are suspicious or oval nodes are suspicious?
Roundish nodes are suspicious. All is normal architecture of nodes.
Okay. Say a patient has come to you, she underwent hemithyroidectomy outside, and in final histopath report, it has turned out to be medullary CA thyroid 1.5 centimeter tumor. Then what will you do?
Sir, I would like to do completion. I would first like to do complete imaging neck as well as to assess for the systemic metastasis. And I would like to proceed with completion thyroidectomy. I would address the central compartment and I will address the ipsilateral lateral compartment if it is not addressed, as well as the contralateral compartment.
Will you do serum calcitonin?
I won't send serum calcitonin in this patient because.
Hello.
Yes, sir.
Your voice got cut.
Sir, yes, I would like to do serum calcitonin. It would further help to refine my evaluation as well as the treatment planning.
So, say calcitonin is, negligible or very low, or less than 5, say, would you still want to do a completion thyroidectomy and neck dissection?
So if the tumor is very small, say less than 1 centimeter, and calcitonin is undetectable, and patient is ready for follow-up, patient is compliant and ready for follow-up, we can observe this patient. But for that, size of the nodule should be around less than 1 centimeter, and serum calcitonin level should be very less, ideally less than 10 or less than 20.
Yeah, so microcarcinoma probably you can observe, but like majority would still be happier doing a completion thyroidectomy and neck dissection along with that. Okay.
Just add one.
Yeah.
In this, before observing the patient, you must have a red proto-oncogene result with you. That red has to be negative. It should not be happen that we are dealing with the familial medullary thyroid and we are observing the patient, because those are aggressive tumors. It has to be sporadic, red proto-oncogene tested. And like you said, very small role. Dr. Syed, can you quote any evidence for it? On what basis you are making these recommendations?
Sorry, ma'am.
So there is only one study. It's by a Mikayachi, something Japanese study, where they have done this prospectively in patients who are red proto-oncogene negative, and they have done the hemithyroidectomy, and they have looked for the kind of whether how did they behave well. For them, 80% of the time patients were doing okay. But small study, small subset, not replicated. Basically, these are rare tumors. We don't have much data. So you have to be very careful. If you're observing a medullary thyroid cancer, you have to have all the ticks with you. You have to have a discussion with the family. Then only you can proceed with observation. Otherwise, safest would be to do completion.
Okay.
Here I had one question, like genetic testing, it takes time to get the report. So we would anyway be waiting for few months.
Patient has already got the tumor out. What you are going to operate on the normal. So it does not much difference.
Fine. So Sayed, when do you consider adjuvant radiotherapy for these patients?
Uh, if the patient has like gross macroscopic or microscopic disease and has bulky cervical lymph node positivity.
तो disease तो है ही ना, तभी तो ऑपरेट कर रहा है.
Microscopic residual disease.
Residual disease, अच्छा.
Yes, gross macroscopic residual disease, or I'm not able to like take out whole of the disease. There is gross macroscopic residual disease, or there is microscopic residual disease,
You're
and
saying
there is
if there's a R
bulky
plus
cervical
resection, then
lymphadenopathy.
you're saying if it's a R plus resection, then you will give radiotherapy.
And also, if there are bulky cervical lymphadenopathy, in that case, I will also like to do adjuvant EBRT.
So if there's only a single central compartment node with say 2 centimeter thyroid nodule, which is medullary CA thyroid, then would you give RT in that case?
I would, if central compartment has been adequately addressed, I would not like to do adjuvant RT.
Right. So even ATA in their guidelines have mentioned that adjuvant RT's role is doubtful. We don't know whether there are several studies, in fact, where they have shown that there's no overall survival advantage. There might be some disease-free survival advantage, but there's no clear-cut benefit in these patients. So if there are multiple nodes or bulky nodes, like you mentioned, then you should consider. Some people consider giving, even if it's a N1A disease, even then they would give RT. Or T3, T4, of course, you should be giving radiotherapy without any doubt. Say if this was a patient with who came 6 months later with a rising serum calcitonin, how will you evaluate that patient? You have operated, there were no neck nodes, only the thyroid gland was positive for medullary CA. There were no neck nodes. It was PT2N0.
Okay.
But on follow-up, patient has come with raised serum calcitonin. When will you call this patient for follow-up, first of all?
We usually ask the patient to follow up every 3 to 6 monthly.
6 months is a good time period for these patients. How will you follow them up? What will you do?
Follow-up history, physical examination, local examination, USG neck, and serum calcitonin and serum CA levels. And further evaluation depending upon if there are any signs and symptoms of
other things are all normal. Okay, other things are all normal. Calcitonin is increasing. Then what will you do?
It depends upon the level of the serum calcitonin. If calcitonin is like less than 150 and patient has no symptoms, signs and symptoms suggestive of distant disease, I will continue my follow-up with and I will look for the serum calcitonin and serum CA doubling time.
So there's no cutoff of 150 per se. You need to look at the previous level and the current level, depending on, like you mentioned, the doubling time.
Yes.
So if there is any modest increase, because calcitonin may still be high in spite of removing the entire disease, calcitonin may still be not close to zero or normal, within lower range. All right. So you need to look at the previous value based upon how much is the doubling time. So how do you evaluate the doubling time?
We follow up patient every 6 monthly and repeat the CA and see how much time it takes to double. Usually,
so 6 months. If within 6 months, if it is getting doubled, then we are worried about it.
Okay.
Moreover, if it is high and it was not high previously, you will not wait for doubling time. You would evaluate the patient whether patient is having metastatic disease or not. What imaging would you prefer in such scenario?
So in such scenarios, I will like to do CCT chest, neck, and triple phase CT abdomen. And
डॉक्टर पृथ्वी ने तुम्हें इतना अच्छा ऑप्शन बताया था, वो यूज नहीं करोगे?
Sir, still my first option will be the same if and I can also consider for PET CT or DOPA PET.
So in metastatic setting, CCT, you can use it, there's no doubt. But I would be in favor of doing a, PET scan or a DOPA scan. Definitely. If those studies are not showing any disease, then you will check for the doubling time after 6 months. Okay. Otherwise, doubling time does not come into play. Okay.
Okay.
Or if the disease is very small, very minuscule disease, which you are not able to treat or not able to find, only then the doubling time is coming into play, because calcitonin may still be high at times. Okay. Say you have found a gross disease, there is some lesion in the lungs, then what will you do?
Dr. Akshat,
Yeah.
hate to interrupt, but we have already reached time, but
Yeah,
you can
already
ask
we'll
questions.
wrap this up. That's fine.
No,
Any
no, you
question
can ask question and then we'll have 5 more
So-
minutes. If there is any,
So there is a concept of stable disease, low volume disease, and asymptomatic disease. If the patient has a low volume asymptomatic disease and it is not doubling time is not very rapid, so I can still follow up this patient without any treatment. And if the patient has systemic recurrence, which is symptomatic, which is rapidly progressing, and serum calcitonin levels are very high or doubling time is very short, and if it is oligometastatic disease, I would like to treat it either by giving EBRT or by giving like other local ablation therapy or treating it with surgical resection.
Okay. When will chemotherapy come into play?
Sir, if the patient has the high burden systemic disease, then only I would like to start some sort of the systemic therapy, either in the form of tyrosine kinase inhibitors or chemotherapy.
So crux out here is it should be progressive disease. Patient should be symptomatic for it, because TKIs also come with their own host of side effects. All right. So you should not be prescribing them just right away. Okay. If disease is progressing in spite of whatever local therapy you have tried, or if patient is symptomatic for that, then you should definitely consider TKI. What TKI would you prefer?
Sir, currently there is role of vandatinib and cabozantinib. These are the two TKIs which are currently available for the treatment of metastatic medullary carcinoma thyroid.
Okay.
you can stop the question probably now.
Sure. All right.
Any question from any, there are no questions as such in the chat box or question answer. If there is any question to Dr. Ankur or Dr. Garima or to any of our panelists, we can also ask. Because I have one question in mind, but Dr. Saurabh, you want to ask anything? Dr. Saurabh is, I think. Okay, so Dr. Ankur, I have one question for you. In continuation to our discussion to this medullary thyroid CA. So what exactly is the role of lutein therapy or DOTA talk therapy, which we just, we just read a little bit and then we just leave it. So can you just tell us what is the, in current era, what is its role?
Yeah, so currently I would say that the role is mainly palliative, in palliative setting in metastatic diseases. When we are done with these tyrosine kinase inhibitors and the disease is still progressive, then we can always consider the option of this PRRT or lutetium dotatate therapy. So proceeding for this, we have to do a DOTANOC PET-CT scan to evaluate the somatostatin receptor status of these primary or metastatic lesions. So if sufficient somatostatin receptor positivity is seen, so we can definitely consider for this PRRT, and this PRRT is usually very well tolerated. So patients, even with borderline renal functions and blood counts, we have given these therapies at older ages also, and the patients, they tolerate it very well. So the only thing is this medullary CA thyroids, they are also having some not very high uptakes in DOTANOC scans. So, but in metastatic disease, definitely they have been given, multiple studies are there, but no randomized clinical trials at present to compare with the alternative forms. But yes, we can definitely try for palliative settings. Yes.
And in what palliative, I mean, like we've discussed, if the patient is symptomatic, then only you should give. So do you
Yes,
also
yes.
have those
Symptomatic patients with rapidly progressive diseases and not controlled with vandatanib or cabozantinib treatment, we can definitely think of this option. And they usually means the overall results are mostly in stable disease. Means they usually result in stable disease or better progression-free survivals. Yes.
Dr. Shilpi, maybe I have missed. There was in this case, the medullary carcinoma, there was structural disease in the lateral neck also. Syed, can you
Yes,
clarify?
there were suspicious nodes on the right lateral neck.
But not on the left side. And the calcitonin was 50, you have told.
Calcitonin was 54 and CA was 15.
So why have you done the contralateral neck dissection?
Sir, there are certain advantages of doing contralateral at the index operation, at the index surgery only. First, it is prognostic. If there is contralateral neck is also involved on final histopathology, it has prognostic significance, like patient has a very low survival. Second, redo surgery is also always difficult in contralateral side. So I would like to do to address contralateral neck on the same index.
That will no. So that will not be a redo the surgery. That will be a when if you are not doing a contralateral neck dissection, the second time you can do the neck dissection. That's right. And then if you are saying that you are doing in all the cases of medullary carcinoma bilateral neck dissection, what you are saying?
If I have no structural disease, I would like to do central compartment as well and ipsilateral compartment. Only if I have structural disease in the central compartment or ipsilateral compartment, I would like to do contralateral compartment.
Okay, so you are thinking that the ipsilateral compartment is involved in this case. That's why ipsilateral lateral compartment. That's why you have done the contralateral neck.
Yes, sir.
Then the theory of doing a neck dissection according to the calcitonin level is not always true.
Yes, sir.
So then probably we can close the session. Thank you very much all the residents. They have done excellent job. Dr. Akhil, Dr. Sandipta, Dr. Syed. And I would like to thank all the faculty, Dr. Akshat, Dr. Ankur, Dr. Garima, Dr. Saurabh, Dr. Vipin for taking out time and making this so informative. Thank you very much.
Thank you, Dr. Shilpi.
Thank you, Dr. Shilpi.
Thank you. Bye.
Good night.
Thank you. Bye.
I want to take one photo.
Actually, the session is very good. There's a comprehensive evaluation and multiple questions. Just like means उनका grand viva types हो गया अच्छे से.
Achha, it's a good concept actually. Actually, I like this. Nahin, Dr. Saurabh? Because they read
Yeah,
also,
yeah,
na? Presenting,
yes.
they read thoroughly. We should actually have a special this thing dedicated only to medullary. That can be done.
Yeah, that can be done because the medullary always a lot of questions are there and it's always very interesting topic. Though the incidence is very low, but the topics are always very interesting.
You know, because you see it less often now, so residents they don't have much idea also because papillary every day you are seeing. Medullary is something which is there's so much in theory. It's quite interesting.
Yes.
Some other time.
Yes, definitely. Okay, bye. Good night.
Bye.